a reverse RAPD. There's really nothing reverse about it. The reverse RAPD happens every single time, but you're really not looking at that eye. So let me just show you what the regular RAPD looks like so that you know that there's nothing unique about it. So in a normal person who has a defect in their pupil pathway on the afferent side relative to the fellow eye, when we shine a light in the eye, both pupils constrict because the afferent pathway is bilaterally innervated. So the signal received by the afferent pathway at the level of the Edinger-Westphal nucleus in the midbrain actually is transmitted to both pupils. And if we swing the light to an eye, in this case, the left, that has an RAPD because it's got nerve damage. When we swing the light from the normal right pupil to the abnormal left pupil, the pupil dilates. However, at the exact same time, because of the bilateral involvement, both pupils are actually dilating when you swing the light to the RAPD eye. So if we ask, if you swing the light from the right to the left in a patient who has a left RAPD, which pupil dilates, right, left, either, neither, both, the correct answer is both. And that is called a reverse RAPD if we're looking at the uninvolved eye. So we can look at the uninvolved eye and detect a RAPD. Normally we don't have to do that because we can just rely on the affected pupil. However, if you have a fixed and dilated pupil and anisocoria, so this left pupil is dilated, but it also can't constrict because it has an efferent damage from a third nerve palsy or some other damage to the iris. We can still swing the light from the left to the right and then back to the left, but this time we're going to be looking at the right pupil. And if the right pupil dilates, then we know that when we swing the light from the right to the left, if the right pupil dilates, that we actually have an RAPD on the left side. And the reason this is important is this reverse RAPD should be tested on every patient who has an efferent pupillary problem where you can't use the regular RAPD because the pupil is fixed and dilated. And so in a third nerve palsy, the resident might get so excited to see the complete ptosis and the eye is down and out like this and the pupil is blown, that they know that's a third nerve palsy. They know that it's a pupil-involved third. They know that a pupil-involved third is an aneurysm of the posterior communicating artery until proven otherwise. They know to do a CT non-contrast to look for subarachnoid hemorrhage, followed by a CTA, then an MRI and an MRA of the head, and a catheter angiogram to look for aneurysm. But what if this patient who has the third nerve palsy actually has an RAPD and loss of vision in the affected third nerve eye? Then the localization moves from a third to a second and a third. And the intersection of 2nd Street and 3rd Street is not at the posterior communicating artery. It is in the orbital apex. And that's how you could easily miss an orbital apex lesion, like the Tolosa-Hunt syndrome, or a mass, or aspergillosis, in someone who you have imaged with every modality you have available to you. CT, CTA, MRI, MRA, and catheter angiogram, but all of the head instead of the orbit. So you need to know that you have to have 2 eyes, but only 1 working pupil is necessary to test for the RAPD. That the reverse RAPD actually happens every single time. You're just not looking at that pupil. And we should use this reverse RAPD to look for a second nerve lesion or an RAPD in a patient who has an efferent pupillary defect, but especially third nerve palsy, because you can miss an orbital apex lesion in a patient you've done extreme imaging on if they have an orbital apex lesion and you only image the head. So remember, the reverse RAPD, there's nothing reverse about it, but use it when you need it.